sa ating lahat. Welcome po sa ating 28th Kapihang OH online edition. This is a monthly session, Kapihang OH, where we tackle the latest updates in the field of occupational safety and health. I hope everyone is safe and healthy wherever you are right now. Kami po dito sa Philippine College of Occupational Medicine, Quezon City Chapter ay nagagalak at napaunlakan niyo po kami muli ng inyong oras para makinig at matuto sa diskusyon natin ngayong gabi. Ako po ang inyong host, Dr. Margo Venus Dasalyaku, Public Relations Officer ng PCOM QCC. Welcome back to Kapihang OH. Thank you for tuning in this 2021. Ngayong gabi ay tatalakayin po natin ang tungkol sa isa sa mga napapanahong topic ngayong gabi, Living the New Normal with COVID-19. The webinar will talk about the recommendations of UP-NIH on how to go about life with COVID-19 pandemic. To welcome us all sa ating 28th Kapihang OH, ladies and gentlemen, our PCOM Quezon City Chapter President, Dr. Catherine Artais-Cariaga.
Maraming salamat, Doktora ko. Magandang gabi po sa inyong lahat na aming tagapanood at tagapagsubaybay mula sa iba't ibang panig ng Pilipinas at sa labas ng bansa. Sa aming kapamilya sa Philippine College of Occupational Medicine, mga kapuso sa Occupational Safety and Health at kapatid sa propesyon ng kalusugan, isang mainit na pagtanggap mula po sa amin na bumubuo dito sa PCOM Quezon City Chapter. Maraming buwan na ang lumipas nang magisnan ng buong mundo ang bagsik ng COVID-19. Isang pandemya na mapahanggang ngayon ay patuloy na umaaligid sa buong sanlibutan. Sa pagpasok ng taong 2021, patuloy pa rin itong nananalasa. Maraming buhay na ang nalagas dala nito. Maraming sektor ng lipunan ang naghihingalo dala ng problemang ito. Bagamat nagpapatuloy na ang pagbibigay ng bakuna sa bansa, madami pa ding kaso ang natala sa datos ng mga tinamaan ng sakit na ito. Marami pa ding ospital ang puno dahil sa pagtaas ng kaso sa bansa. At sa pagpapatupad ng mahigpit na protokol at polisiya at sa pagkasailalim ng ibang lugar sa bansa ng ECQ sa loob ng mahigit isang buwan, unting-unti nang bumababa ang mga kaso. Patuloy pa ring umaasa ang mga mamamayan na mawawakasan din natin ang pandemyang ito. Kaya kami po sa sektor ng kalusugan ay patuloy na nakikipag-ugnayan sa ating mga kinauukulan upang maghatid ng kaalaman upang umigting ang pananggalang ng ating mga kababayan sa problemang dulot ng COVID-19. Kaya po ngayong gabi sa ating virtual na pagtitipon-tipon, kami ay lubos na nalulugod dahil kasama po natin ang mga eksperto sa larangan na ito sa aming ika-28 Kapihan sa temang Living the New Normal with COVID-19. Tara, tayo po ay makinig at matuto ngayong gabi. Maraming salamat po at isang mapagpalang gabi po muli sa inyong lahat.
Maraming salamat po, Dr. Cariaga. Ladies and gentlemen, my dearest colleagues, and to all our beloved guests from all sectors of workforce, we're very honored tonight at napaunlakan po tayo ng ating mga panauhing pandangan. To introduce our distinguished and honorable guests tonight, may we call our Chapter Chair Finance Committee, Dr. Jason John J. Cabigot.
Good evening, everyone. It's my honor to introduce both our distinguished speakers for tonight. Our first speaker is the Director of the Institute of Clinical Epidemiology, National Institute of Health, UP Manila. She is Dr. Marissa Alenjandria. She is also a fellow of the Philippine College of Physicians and a fellow and president of the Philippine Society of Microbiology and Infectious Diseases. She is also the co-chair of the Committee on Standards of Care of the same society. She is the Associate Dean for Research and the head of Research and Implementation Development Office of UP Manila College of Medicine. She is ranked Professor 12 of the Department of Clinical Epidemiology, UP Manila, and a Clinical Professor of Infectious Diseases Section, Department of Medicine, UP Manila, PGH. Again, she is Dr. Marissa Alenjandria. Our second speaker is an Associate Professor of the Department of Medical Microbiology, College of Public Health, UP. She is Dr. Evalyn Roxas. She is also a Clinical Associate Professor of the Division of Infectious Diseases, Department of Medicine, UP Manila, Philippine General Hospital. She is also a Fellow and Diplomate of the Philippine College of Physicians and the Philippine Society for Microbiology and Infectious Diseases. She is the President of the Philippine Hospital Infection Control Society, an infectious disease consultant of Manila Med and UP Manila Philippine General Hospital, and the head of the Section of Infectious Diseases, Department of Medicine, Manila Med. Again, she is Dr. Evalyn Roxas.
Thank you, Dr. Cabigon. For our first speaker, let me call on Dr. Alenjandria.
Thank you for the kind introduction, and thank you to PCOM Quezon City chapter for this invitation and for the opportunity to share with you our work on the living CPG, the recommendations on adjunctive interventions for COVID-19, and to be followed by the non-pharmacological interventions by Dr. Eva Roxas. Okay. So thank you also to Dr. Ces, Diana, and Dr. Marlu Renales for this invitation. Okay, so can everyone see my screen?
Yes, ma'am.
Thank
Go
you.
ahead, doctor.
Okay, so for this evening, we will be talking about the evidence for vitamins B, C, D, zinc, melatonin, and acetylcysteine, Ibuprofen, renin, androstensin, aldosterone blockers, fatty acid supplements, and VCO. Okay, so before I give you the recommendations, I just like to quickly share to you the methods on how we arrive at the recommendations. So we use the internationally accepted methodology, that is GRADE, and we start off with formulating the questions, and then our reviewers search the literature, and then they appraise the quality of the evidence using GRADE. And with the GRADE approach, the quality of evidence is graded as high, moderate, low, or very low. High if the evidence is already very definitive that we are that the intervention is beneficial, harmful, or of no benefit. Moderate if we think that the ongoing research will still change the direction of the recommendation, whether it's beneficial, no benefit, or harmful. Low and very low if the research will again change recommendation. Very low if we are very uncertain, because the quality of the evidence is either flawed, or there are very few trials available to back up the recommendation, or there is no evidence at all to back up the recommendation. So based on the assessment of the quality of the evidence, the consensus panel will vote on whether the recommendation is strong or weak or conditional, depending on the quality of the evidence and the magnitude of the benefit or the harm. If the benefit definitely outweighs the harm, then the panel may opt to vote for a strong recommendation. However, if the benefits and the harms closely balance each other, the panel may opt to vote or grade it as a weak or conditional recommendation. Okay. And I'd just like to take this opportunity also to express gratitude to PCOM for the members of PCOM who participated in this Living CPG as consensus panel members. So we have Dr. Romel Punongbayan, Dr. Edmir Macabulos, and Dr. Ria Fajardo. They participated in the consensus G recommendation. So they participated in the voting of the recommendations for whether they will be strong, conditional, or weak recommendation. And as I mentioned, in grading the recommendation, the quality of the evidence was considered, the magnitude of benefits and harms, values and preferences, issues on cost, equity, feasibility, acceptability were also considered in the end. So for strong recommendations, we word it as we recommend. For conditional, we suggest. Yeah. And you will see later also that we have recommendations where we say there is insufficient evidence or there is no recommendation. Insufficient, or if the quality of the evidence is low or very low, or then the trade-offs between benefits and harms are closely balanced, values and preferences, resource implications are still not known, or management options have very different undesirable consequences, or if there are still a lot of ongoing trials, and we think that these ongoing trials will have an impact on the recommendation, so we opt to wait for the results of these ongoing trials rather than make outright recommendations for or against the intervention. Okay, so that's for the methodology. Now let's start off with the adjunctive interventions. So the next 15 minutes or so, we'll just focus on this adjunctive intervention. So let's start with vitamin D. So why was this considered as a possible adjunctive treatment for COVID-19? So studies have shown there are some studies which suggest that vitamin D lowers the risk of COVID-19 complications by attenuating the cytokine storm through lowering of the renin and ACE expression. So we know that SARS-CoV-2 upregulates renin and ACE2 inhibitor expressions, leading to a buildup of angiotensin 2. So once the virus enters the cells through attachment to the ACE2 inhibitor and then replicates, it leads to inflammation, enhanced lung permeability, and ARDS. And it is hypothesized that the mechanism of vitamin D is to attenuate the cytokine storm and lower inflammation, fibrosis, and apoptosis. However, the available clinical trials, so far, there are just 3 RCTs that we found on vitamin D for COVID-19. And this trial showed no benefit in terms of mortality, need for oxygen, and ICU admission among hospitalized COVID-19 patients. So because of this, our recommendation is there is still insufficient evidence to recommend vitamin D supplementation as adjunct treatment for COVID-19. So the quality of evidence is still very low. So we are not recommending it yet. So insufficient evidence for or against the use of vitamin D. Next is vitamin C. Okay. So we all know that vitamin C is a water-soluble vitamin, and it's required as a cofactor in many enzymatic reactions. It promotes phagocytosis, chemotaxis of leukocytes, development and maturation of T lymphocytes, and its antioxidant properties, is the one that leads to attenuation of inflammation. So we know that COVID-19 has two phases, the viral phase and the inflammatory phase. Okay. So the hypothesis or the idea on why vitamin C again has been hypothesized for COVID-19 is based on experience on the use of vitamin C in viral upper respiratory tract infections. So this systematic review of good quality studies shows that vitamin C can decrease viral upper respiratory infections such as the common cold among those exposed to extreme stress, physical stress. And it's usually regular oral vitamin C, that is less than 1 gram rather than 1.5 grams, the therapeutic dose, has been shown to have a beneficial effect in common colds. So it reduces the duration of viral URTI, so like 8 grams per day. Now, does that apply in COVID-19? And this is based on the reviewers. They gave this opinion that because of the small benefit, prophylactic daily vitamin C dosing does not seem worthwhile under normal circumstances. So it's usually we see the benefit of vitamin C under stress, and then just using the regular doses. But since many URTIs are caused by coronaviruses, there is no reason to assume that vitamin C would be completely ineffective against COVID-19. Hence, there were this case series showed that 17 of 18 patients with SARS-CoV-2 with ARDS had undetectable vitamin C levels, and one patient had low levels. So it was hypothesized that supplementation with vitamin C might improve the outcomes of COVID-19. So it was suggested as a possible therapy, and clinical trials were done. However, the clinical trials, there were just 3 clinical trials that we were able to find, and therapeutic IV vitamin C, however, showed no significant benefit in terms of reducing mortality and the need for invasive mechanical ventilation among hospitalized patients with COVID-19. So again, there is insufficient evidence to recommend vitamin C as an adjunctive treatment for COVID-19 on low quality evidence. Okay. Now, vitamin B. Okay. So we are all familiar with the vitamin B complex. That's B1, B2, B5, B6, B9. And it contributes to cell functioning and energy metabolism to create and maintain healthy cells. And in particular, vitamin B1 has some anti-inflammatory effects. B6 cell production, while B3 and B12 affects the immune system. So when combined, it can boost the immune system, and hopefully it can translate to beneficial effects when taken as an adjunctive treatment for COVID-19. However, there is only one observational study so far that look at the effect of vitamin B as an adjunctive treatment among hospitalized patients. And in this observational study, single observational study, it showed a decrease in the need for oxygen including ICU support in a small number of patients only. This is a small observational study. However, there was no benefit in reducing the need for ICU. Okay, so with this inconclusive and minimal benefit, no, or inconsistent results of the observational study in terms of whether it's beneficial or not, the panel opted to make a recommendation to suggest against the use of B vitamins as an adjunct in the treatment of patients with COVID-19. In addition, there was one also observational study which showed that high plasma levels of vitamin B12 was associated with increased risk of mortality. Hence, this recommendation, this suggestion actually not to use vitamin B as an adjunct in the treatment of patients with COVID-19. Okay. So we can look at zinc, one micronutrient. No, Zinc's antiviral effect is through the inhibition of SARS-CoV-1. So it's in vitro studies. So the rationale for the use of zinc is based on studies on SARS-CoV-1. Okay, and this study suggests that zinc may reduce severity and duration of symptoms of other viral respiratory tract infections when used as an adjunct treatment. No? Okay, so basically the action, no, the hypothesized action of zinc is to inhibit viral replication, and I'll show you later some systematic reviews on the use of zinc in other viral respiratory tract infections. For COVID-19, however, there is only one clinical trial, and this showed no mortality benefit, no, in COVID-19. It did not reduce mortality in the clinical trial. There were, however, 3 observational studies which showed reduction in mortality. However, these are low quality evidence, no? So, and also these trials also showed no benefit in the need for mechanical ventilation, and it also did not reduce symptoms. Okay. Hence, again, there is insufficient evidence to recommend zinc as adjunctive treatment for COVID-19. Very low quality of evidence, and there are still several ongoing trials on the use of zinc for COVID-19. Okay, and then here, I just like to share with you the results of systematic reviews of clinical trials on the use of zinc for viral upper respiratory tract infections other than COVID-19. No? So here, this systematic review shows that zinc can shorten the duration of viral URTIs, no, in both adults. And if you use a higher dose, it showed a much better shortening, no, of the duration of viral URTIs here. So high dose here is, it can reduce, no, the duration by as much as 4 days. No? So 2 to 4 days. And then for low dose zinc, it's about half day to 2 days. No? Okay. So, and the dose also, no, so more than 75 milligrams can reduce viral URTI. No? And these are the zinc preparations available in the Philippines. So what I'm just saying here is that you can still use zinc for URTI, but you cannot use it as adjunctive. If you use zinc in COVID-19, there is no assurance that it will improve the outcomes of COVID-19. Okay, so we do not have evidence, direct evidence that zinc will improve the outcomes of COVID-19. What we have is evidence on reducing the duration of viral upper respiratory tract infections in general. Okay, next is melatonin. Okay, so melatonin is an anti-inflammatory and antioxidative molecule. Okay, it is protective against acute lung injury or ARDS caused by viral and other pathogens, and it has been proposed as an adjunctive therapy for COVID-19 because of its antioxidant, anti-inflammatory, and immunomodulatory effects, as well as its antiviral action. And we all know that melatonin is used to restore the circadian rhythm, no, from the sleep-wake cycle. So it can be used, no, in to control delirium brought about by social in severely affected patients in the ICU to isolation. Okay. So as I mentioned, melatonin is being proposed as an adjuvant medication in the regulation of the inflammatory phase, no, of COVID-19 to provide support for patients with ARDS. Okay. However, there is only one RCT. No, we were only able to find one RCT, and this RCT showed very low certainty of benefit for mortality, time to recovery, hospital stay, or pulmonary involvement. And currently, there are still in the country also. So for now, there is insufficient evidence to recommend melatonin as an adjunctive treatment for COVID-19 based on very low quality of evidence. So as I mentioned, there are still several ongoing trials on COVID-19, on melatonin. Next is the use of IV N-acetylcysteine. No? So we all know that N-acetylcysteine is a mucolytic, and it's an antidote against paracetamol intoxication. No? So it has antioxidant properties, antibacterial properties, which may reduce the risk of secondary bacterial infection as a complication in COVID-19, and may also be of benefit for COVID-19 related liver injury. We found one RCT comparing IV N-acetylcysteine to placebo among adults with confirmed COVID-19 requiring oxygen. However, in this RCT, no significant difference was found in terms of mortality, the need for invasive mechanical ventilation, the need for ICU, and it also did not reduce the length of hospital stay and ICU stay. And then we also found one systematic review, no, of RCTs on the use of NAC in ARDS in general. No? So, and systematic review also did not show any benefit in terms of reducing mortality, duration of ventilation, but it shortened the ICU stay. Okay. So based on this evidences, the recommendation at this time is we do not recommend the use of IV N-acetylcysteine as adjunct treatment for patients with COVID-19 infection based on moderate quality of evidence. However, N-acetylcysteine can still be used for its mucolytic indication, no, in the ICU or among intubated patients. Now we go to Ibuprofen. No? So especially during the early part of the pandemic, there have been a lot of questions, no, on whether Ibuprofen and renin-angiotensin aldosterone blockers, no, can aggravate the outcomes of COVID-19. And here we found that observational, this is though just based on observational studies, no, it was shown that ibuprofen was not associated with an increase in death, ARDS, ICU admission, or shock. So the use of ibuprofen as a symptomatic treatment, no, for patients with COVID-19 can still be done. So it is suggested that ibuprofen may still be used, no, for its antipyretic and anti-inflammatory effect, no, but it is not recommended for treatment, no, of COVID-19. Okay, so it's just for symptomatic treatment. Okay, and based on the observational studies, concurrent use of ibuprofen was not associated with worsening of COVID-19 outcomes. Okay. Next is the renin-angiotensin aldosterone blockers. Okay, it was thought that during the early part of the pandemic that RAS blockers the ACE2 receptors and worsen COVID-19, okay, through the ACE2 enzyme that the SARS-CoV-2 enters human cells. Okay, since it is through the ACE2 enzyme, no, that the SARS-CoV-2 enters human cells, and by upregulating the ACE2 receptors, it was thought that it would worsen COVID-19. On the other hand, this upregulation may be beneficial since they counteract the increase in angiotensin II formation, which leads to increased pulmonary vascular permeability and consequent pulmonary edema and reduction of pulmonary function. Okay. However, the RCTs, no, we found 2 RCTs which looked at the effect of continuing or discontinuing this renin-angiotensin blockers, and we found that these RCTs showed no increase in mortality, or it did not increase the need for ICU or mechanical ventilation, and it did not also lead to COVID-19 progression. No? So continuing maintenance RAS blockers for hypertension is recommended among patients with COVID-19. Okay, because so the benefit or the harm, no, associated with discontinuation, no, is given weight, because if you discontinue these maintenance medications for hypertension, it can lead to heart failure. And on the other hand, if you continue, there is no harmful effect, no, as far as the COVID-19 outcomes is concerned. As we've seen in the RCTs, it did not result in worse outcomes. So therefore, it is safe to continue the maintenance RAS blockers for hypertension, no, if a patient with hypertension develops COVID-19. Okay. Next, we now move to fatty acid supplements and VCO. Okay, so I think this is the last 2 interventions. So we all know that essential fatty acids are polyunsaturated fatty acids that are necessary for health, no? And it is obtained from food. And the main omega-3 fatty acids are the alpha-linolenic acid, EPA, and DHA. And we get this from shellfish and fish. No? And it is all hypothesized that omega-3 fatty acids and its bioactive lipid mediators may reduce inflammatory markers, reduce oxidative stress, and as such, it can mitigate the hypercoagulation, no, that is seen in COVID-19, such that it can lower cardiovascular complications due to COVID-19. And we know that omega-3 supplementation is recommended to prevent clinical cardiovascular events. No? Okay. And however, we only found one RCT, on fatty acid supplementation, and this small RCT showed a small reduction in mortality on efficacy, but intention to treat analysis, we did not see the benefit anymore. Okay, so based on that, the low quality of evidence of that single RCT, there is still insufficient evidence to recommend the use of fatty acid supplements as adjunctive treatment for patients with COVID-19. Okay. And then last is the VCO. Okay, so there have been some press release on this, and the rationale for, or the proposed hypothesis mechanism of action is for VCO is on its anti-inflammatory, antioxidant, and antiviral properties. So it's rich in lauric acid, pharmacologically active metabolite monolaurin. Okay, and then there is one small low-quality clinical trial involving HIV and AIDS patients way back in the early 90s, which showed that VCO treatment led to an increase in CD4 and lymphocyte counts and reduction in viral load. But this was really never established in large RCTs. So we've not been using it for our HIV patients. And now it's being studied among COVID-19 patients. So currently, there is still no published study assessing the efficacy and safety of VCO as an adjunctive treatment for COVID-19. We have one ongoing study in the hospital, and then another RCT that's ongoing also in Indonesia. And then the one that's been written in the press is a community-based trial. It's a small trial on suspect cases of COVID-19. So we have not seen yet the full report of that study on whether it is really beneficial in COVID-19. Okay. So for now, we await the results of the RCTs and the full report to be assessed, for us to be able to come up with a recommendation on VCO. So we do not have any evidence at this time to recommend the use of VCO as adjunctive treatment for COVID-19. Okay, so that's it. So just to summarize what we've discussed. So this table is a color-coded summary based on the quality of evidence. So for the use of the renin-angiotensin aldosterone blockers for hypertension, it's a strong recommendation to continue the use of these maintenance blockers for hypertension, as it does not worsen COVID-19 outcomes. And then Ibuprofen can still be used for symptomatic treatment of COVID-19, but not for definitive treatment. Okay, so, and then we suggest against the use of vitamin B because of the potential risk for increased mortality with high plasma levels of B12. So there is still very little evidence on vitamin B, so we suggest against the use. And then we also recommend against the use of N-acetylcysteine as adjunctive treatment for COVID-19. And we have insufficient evidence for the following: zinc, IV vitamin C, vitamin D, melatonin, VCO, and oral fatty acids. There are several ongoing trials on these adjunctive interventions. Okay, so for now, the evidence we do not see definitive benefits or harms on the use of these adjunctive interventions. Okay, so thank you for your attention.
Thank you, Dr. Alenjandria. Our next speaker, Dr. Roxas.
So thank you, ma'am, and thank you, Ma'am Isa, and thank you for that introduction. So let me just share my slide. I will stop sharing. So can you see my slide?
Yes, ma'am. We can see it.
Thank you. So again, good evening to all of you po, to all our participants. And I would like to thank the Philippine College of Occupational Medicine through, of course, Ma'am Isa for inviting me and also for giving me this opportunity to share the recent clinical practice guidelines, living clinical practice guidelines on COVID-19. Particularly, I'll be discussing the non-pharmacological intervention. So this is my objective, to present the latest recommendations on COVID-19 non-pharmacologic interventions. So since Ma'am Isa discussed the living CPG recommendations on the pharmacological aspects, so I will be discussing the non-pharmacological part. So this was mentioned by Ma'am Isa a while ago. So I'm part of the steering committee of the Philippine COVID-19 living recommendations, and I will be presenting the April 27, 2021 update because we had our first release of this living CPG in March, and we've updated it in last April 27. So since this is a living CPG, so we have almost continuous updating of the recommendations. So of course, we have Ma'am Isa as the chair of this living CPG. And again, I'm representing the Philippine Hospital Infection Control Society as I am the steering committee member for the non-pharmacological intervention. So before I start, I would like to acknowledge also the consensus panel members of the NPI group. Okay, Dr. Fajardo is part of the NPI, and I believe, as mentioned by Ma'am Isa, is a member of PCOM. So unlike the pharmacological interventions for COVID-19, where there are studies that can support the recommendation, for the non-pharmacological interventions, there is not much evidence-based, and we rely on the inputs of the consensus panel members are very important in arriving in our recommendations. Okay, so to begin with, so we had our first question, which is, are cloth masks effective in preventing COVID-19 infections? So we have our reviewers also, and they search for studies to answer this question, and they were able to find in vitro studies and to randomize controlled trials and meta-analysis to answer this question. So first is that they found this study, although the outcome was influenza-like illness because there were no studies that directly stating COVID-19 infection as the outcome. So using this study and having healthcare workers as the participants with 1,319, so comparing cloth masks with surgical masks for healthcare workers, so it showed harm. Okay, so the result showed harm when healthcare workers are wearing cloth masks as compared to those healthcare workers wearing surgical masks. So when the participants then were found to be the general public, so there was a study last 2020 from the Annals of Internal Medicine. So again, comparing surgical mask versus no face mask at all, but the participants here are the general public. So the RR was 0.10 and it was interpreted as not significant. So again, I would like to emphasize here that the participants are the general public. So a more recent study published in the Lancet last 2020, now combining the general public and the healthcare workers. And here the outcome is SARS infection. So not really COVID-19, but SARS infection. And comparing the surgical mask or a similar mask with 12 to 16 layers compared to no face mask at all. Okay, so it showed benefit towards those who are wearing surgical masks compared to those not wearing face masks at all. So again, the participants here are both the general public and the healthcare workers. So with all of these studies and upon review and presentation to the consensus panel members, so the Living CPG recommendation on the use of cloth masks as a prevention and control measure for COVID-19 infection is, so we recommend that healthcare workers, so not directly taking care of COVID-19 patients and other persons with high risk of exposure to COVID-19 should use properly fitted surgical masks instead of cloth masks. So again, based on the studies on the group of population, the healthcare workers, but we emphasize here that healthcare workers not directly taking care of COVID-19. So maybe healthcare workers in the non-COVID wards, okay, or the healthcare workers in other facilities not directly taking care of COVID-19. So the recommendation is to use properly fitted surgical masks instead of cloth masks. So the panel, this has a moderate quality of evidence and the panel gave a strong recommendation. On the other hand, we suggest using cloth masks, again, that fit snugly on the face and made at least 2 layers of cotton, example of a t-shirt fabric or a non-woven nylon with aluminum nose bridge for the general public who is assumed to have a low risk of exposure compared to the healthcare workers to COVID-19 in outdoor or indoor areas to prevent COVID-19 infection. So this has low quality of evidence and the panel gave conditional recommendation. So that's question number 1 in NPI. So another question answered by the group is that, is ionizing air filter effective in reducing SARS coronavirus 2 virus transmission in public spaces with sustained community transmission? So again, we have our reviewers and they were able to find 5 experimental and 1 systematic review as evidences. However, these are indirect evidences. So I'm sure we are all familiar with this ionizing air filter. So lumakas nga pong business nila last year, no, in 2020. But how do ionizers work? Okay, so mainly ionizers is on the filtration efficiency. So we have this diagram showing that ions. So with ions, they clean the air by precipitation. Okay, so in the surfaces or the receptacle, and is high efficiently reducing the particulate matter. As we all know, SARS coronavirus 2 is a virus with a very small size. Okay, so the key findings in the review show that those ionizing filter units with higher emission rate can provide particle removal efficiency, and those with higher emission rate provided higher removal efficiency also. So several studies mentioned that. Ionizing air filters alone or even with HVAC can reduce the particulate matter concentrations, including bacteria and spores. However, we also found out that with the use of all these ionizing filters, there is the possibility of development of ozone, which is a health concern among commercially available ionic air cleaners. So there was also no intervention studies conducted on ionizers on improving health outcomes, particularly reducing infection. And even the CDC said that ionizers are emerging technologies, but without clear evidence showing its efficacy for COVID-19. So with this, our recommendation is that So we recommend against. So a while ago, this was mentioned by Ma'am Isa that if there's low quality of evidence, so the review showed more of the harm rather than the benefit. So we recommend against the use of ionizing air purifier to reduce COVID-19 transmission in the community. However, this is of low quality of evidence, but the panel gave it a strong recommendation. So another non-pharmacological intervention are foot baths. So another in thing last year. So we have foot baths in almost all the buildings, diba? Entrances in the buildings or in the malls. So are foot baths really effective in prevention and control of COVID-19 infection? So our reviewers did not find any randomized controlled trials to directly answer this question. Actually, in almost all of these non-pharmacological interventions, as I've said, it's very difficult to look for a randomized controlled trials as compared to the pharmacological intervention. So just a background, so foot baths are commonly used in agricultural facilities to prevent potential spread of other microorganisms that survive in the dirt. So I think ito is before the COVID era, no? Because ngayon very popular na si foot baths. However, there's still no study, ongoing clinical trials that directly assess the effectiveness of foot baths. So there was one case report of SARS coronavirus 2 particles found on the front of shoes of health professionals in Singapore, but it was not detected elsewhere in the same hospital. The WHO in last year's report also reminded all of us that disinfecting and cleaning environmental surfaces did not include foot baths, but emphasized that floors and very low-touch surfaces, so floors are considered as very low-touch surfaces, should be disinfected last as compared to the high-touch surfaces like doorknobs or the keyboards in the computer. We also found out that direct application of properly and freshly prepared disinfectants, particularly sodium hypochlorite in the context of COVID-19, in appropriate concentration remains to be the ideal and is more effective. So with all of this, the recommendation of the Living CPG is that, again, we recommend against the use of foot baths, for the prevention and control of COVID-19 transmission. So this has very low quality of evidence, again, because we did not see any RCTs or any other studies, but the panel gave a strong recommendation. So another non-pharmacological intervention, so misting tents. Okay, so are misting tents or disinfection chambers effective in preventing and controlling COVID-19 infection? So I remember in the early parts of the pandemic last year, so when we tried to look for all of these interventions to combat the virus, so we itong misting tents emerged. However, the reviewers still did not find any randomized controlled trials to directly answer this question. So this is the misting tent. Okay, so again, nung early parts last year, maraming gumagamit. But eventually, with the recommendations coming from WHO and even our very own Department of Health to use against it, so medyo nabawasan yung use. So we found out that there is no direct evidence that spraying can prevent an infected person's ability to infect another person. So there is an indirect evidence of the effective viral inactivation after application of cleaning products like alcohol, the bleach, detergents, glutaraldehyde, iodine-containing detergents, and hydrogen peroxide compounds. Moreover, when used outside its manufacturer's recommendation, so there were reports of adverse reactions, and repeated actions and increased duration of exposure can magnify its harm. So the commonly reported adverse effects were effects on the skin, eyes, nose, mucosa, and the respiratory tract. So again, last year, April 10, 2020, our Department of Health released this announcement stating that spraying or misting does not protect against COVID-19 and can even cause harm. Okay, so what does it mean? DOH does not recommend spraying or misting. There's no evidence to support its efficacy in preventing and controlling the transmission of the virus. And moreover, there is a harm associated with the use of these misting tents. So with this, the recommendation of the guideline recommendation is that we recommend against the use of misting tents or disinfection chambers for preventing and controlling COVID-19 transmission. So again, because of the lack of evidence, it has very low quality. However, the panel still gave a strong recommendation. Okay, so another intervention, so ultraviolet lamps, so UV lamps, another in thing last year, no? So UV lamps effective in infection prevention and control of COVID-19 in public spaces and locations with sustained community transmission. So just like the first two interventions, there were no randomized controlled trials found, but just to give a background on ultraviolet lamp, okay, so particularly we use UVC. So actually UVC is an adjunct to the mechanical disinfection for COVID-19 for SARS coronavirus 2. So it's an additional, particularly if we use the UVC, ultraviolet light C, and the most effective UVC is that of 200, that with 250 to 280 nanometers wavelength. So UVC breaks DNA and the RNA strands of the virus, then eventually leading to cell death. So it is used to disinfect surfaces in healthcare facilities, so such as the hospital. However, there is no direct evidence against COVID-19. And what is more highlighted here are the adverse reactions associated with the use of UVC, okay, such as erythema, ocular itching, blurring, and conjunctival injections, particularly if we don't follow the manufacturer's safety instructions, and even the ozone formation. And all of these adverse reactions are dependent on the exposure duration, intensity, and the number of cycles. So some other groups like WHO do not recommend its use to disinfect hands or other skin surfaces because of its harm. And the DOH also warns against the use of devices emitting UV to disinfect objects or surfaces because, again, of its adverse effects. So unfortunately, there's still no ongoing clinical trials found on this. So with this, our recommendation is that we recommend, again, against the use of UV lamps or other UV devices in place outside of a controlled clinic or hospital setting to prevent and control COVID-19 transmission. Because in the hospitals, I've said, we usually use UV lamps, but outside hospital or controlled clinic setting, we do not recommend it. So this has a low quality of evidence, but again, the panel gave a strong recommendation. Okay, so I think this is 6 non-pharmacological intervention. How about HEPA filters? So HEPA, or high efficiency particulate air filters. So are they effective in infection prevention and control of COVID-19 in public spaces and locations with sustained community transmission? So again, just like the previous interventions, no direct evidence, or if there are evidences that we found, so it's indirect evidence supporting its use. So just to review, so HEPA filter, they are pleated mechanical air filter with at least 99.95% or 99.97% capacity to filter dust, pollen, molds, bacteria, and other airborne particles with a size of 0.3 microns. So HEPA filters are believed to assist in reducing the risk of transmission through removing particles or large droplets to which pathogens may be attached. So the reviewers found all of these studies, okay, so non-clinical case series, which again are indirect, so showing benefits, okay, particularly in terms of particle reduction, okay, so number of healthcare workers infected with COVID-19, okay, particulate penetration of PPE with modified HEPA filter, and filtration efficiency, because that's the actual action of HEPA filter. So other groups recommendation like the American Society of Heating, Refrigerating, and Air Conditioning Engineers state that HEPA filters more than 99.95% efficient of capturing airborne virus particles associated with SARS-CoV-2. So CDC has this recommendation that portable HEPA filter or fan seems to help enhance the air cleaning, okay, and in higher risk settings, help clinics, medical testing locations, or public waiting areas. And we also, last year, we also had these guidelines from PSMID, FIX, and PCP, wherein we recommended already that HEPA filters can provide additional benefit in improving the air quality, especially in settings where adequate ventilation cannot be achieved. So with our 2021 Living CPG, so our recommendation in terms of HEPA filter is that we suggest, okay, so unlike the first few interventions wherein we really, we recommend against the use of it, with HEPA filter, we suggest the use of HEPA filter as an option to improve the air quality of COVID-19 prevention and control, particularly in indoor spaces wherein adequate ventilation can't be achieved. So this has low quality of evidence, and the panel gave a conditional recommendation. Okay, so another non-pharmacological intervention. So how about the contamination methods for N95 reuse? So last year, early parts or middle part of the year, okay, of the pandemic, there were issues of inadequate supply, particularly of N95. So that's why even the IDSA, Infectious Disease Society of America, has this recommendation of extending use of N95 or even reusing it or even reprocessing it. As we all know, ideally, pre-pandemic time, so N95, one use, and then it should be disposable. But during last year with the pandemic and the emergence of the issue of inadequate supply of the PPEs, particularly N95, the issue of reprocessing or reusing of this N95 emerged. Okay, so some of the reprocessing and the contamination of N95 masks were the following. So use of UV, okay, 70 degrees dry heat, use of 70% ethanol, the vaporized hydrogen peroxide or the VHP were some of the reprocessing methods. So this is an example of vaporized hydrogen peroxide, which is actually the recommended or the best reprocessing method that exhibited the inactivation of SARS coronavirus 2. So this is just a picture of VHP, and N95 can be decontaminated and reused for up to 3 times with the use of VHP. However, this is not a common reprocessing method in hospitals, in many of the hospitals. That's why most of the hospitals use this form of reprocessing, the UV radiation. Okay, so just like the VHP, N95 can be decontaminated up to 3 times. So the current Living CPG team has these key findings. So there is limited evidence on the use of vaporized hydrogen peroxide, UV, heat, and autoclave in decontaminating SARS coronavirus 2 and maintaining N95's physical and functional integrity. Because we have to remember that if we deprocess this N95, after reprocessing, the N95 function should still be there. Okay? Otherwise, it will be useless. So the different decontamination methods had varying effects on different temperatures and type of N95 mask. And there is no evidence on the use of bleach, microwave heat, steam, soap, and water in decontaminating SARS coronavirus 2 laden N95 masks. So with this, our recommendation is that in situations where there is shortage of filtering face piece respirator, FFR, we suggest the use of the following decontamination methods: hydrogen peroxide vapor, or the VHP or the HPV, ultraviolet germicidal irradiation, UVGI or the UV, moist heat and peracetic acid dry fogging system or PAF as options for N95 mass decontamination as recommended by the manufacturer based on their ability to reduce the SARS coronavirus 2 load and infectivity while still maintaining the N95 mass integrity. Although this has low quality of evidence, this was also given a conditional recommendation by the panel. So again, we emphasize only in instances where there is shortage of respirator. Otherwise, if there is an adequate supply of the respirator, then we do not recommend decontamination because ideal still one use only. Also, we recommend against the use of autoclave and alcohol as a decontamination process for N95, as these methods alter the respirator's integrity and degradation filtration efficacy. So this is very low quality of evidence. However, the panel gave a strong recommendation. Okay, so last three non-pharmacological interventions. How about the use of PPEs in different situations? So what is the appropriate PPE to use during surgery to reduce SARS coronavirus 2 virus transmission? So the reviewers found direct evidence from these studies, 2 cohort studies, 2 cross-sectional, 1 case series, and indirect evidence from 8 experimental studies. Okay, so we recommend the appropriate PPE as follows, okay, during surgeries. So a mask, N95 at least, since this is a healthcare facility, okay? So N99, FFP2 or FFP3, a fluid repellent sealed well-fitting long gown, double gloves with tabs to grab, disposable apron, full face shield or goggles or visor, a scrub hat, and a disposable shoe covers or dedicated closed footwear among surgeons engaged in aerosol-generating procedures of suspected or confirmed COVID-19 patients. However, this has very low quality of evidence, but the panel gave a strong recommendation. So just to reiterate, the aerosol-generating procedures, we have all of these AGPs, bronchoscopy, CPR, colonoscopy, the use of high-flow oxygen, so nasal endoscopy, tracheal intubation, tracheotomy. So whenever the surgeons are performing these aerosol-generating procedures with suspected or confirmed COVID-19, so the suggested or the recommended full PPEs are the following. Okay. So how about in the outpatient setting? So that's at the OR. How about in the outpatient setting? So what is the appropriate personal protective equipment? So our question is, among healthcare workers in the outpatient setting, does N95 mask compared to surgical mask reduce the risk of SARS coronavirus 2 transmission? So for this particular question, the reviewers found a randomized clinical trial, 1-RCT. So, so they found out that N95 respirators versus medical masks, okay, has associated adverse events, so particularly in the outpatient setting. So there was no serious study-related adverse events, but 19 participants reported skin irritation and worsening acne of years 3 and 4 at one study site in the N95 respirator group as compared to those wearing the usual medical mask. So recommendations also from WHO state that in the absence of aerosol generating procedures, WHO recommends that workers providing direct care to COVID-19 patients should wear a medical mask in addition to other personal protective equipment that are part of the droplet contact precautions. So in care settings of COVID-19 patients where, again, aerosol generating procedures are performed, then the recommended masks for healthcare workers are respirators, particularly N95 or FFP2 or FFP3 standard or an equivalent. So how about other PPEs? So that's for face masks in the outpatient setting, other PPEs in the outpatient setting, particularly face shield. So the reviewers found one observational study with direct evidence from before and after study. So this study, this is a 2020 study, showed a significant difference favoring the use of face shield among healthcare workers in terms of preventing SARS coronavirus 2 infection. So also CDC recommends against the use of face shields alone and should be used as part, okay, of other personal protective equipment, which includes N95 respirators when handling aerosol generating procedures and surgical masks if not performing AGPs. So with all of this, the Living CPG has this recommendation in terms of the appropriate PPE in the outpatient setting. So we recommend the use of at least surgical face mask and face shield for protection against COVID-19 infection among healthcare workers in the outpatient setting. Take note, not performing aerosol generating procedures. Additional PPE such as medical gowns and gloves should be worn as part of the standard precautions during the performance of other procedures. So this is very low quality of evidence. However, the panel gave strong recommendation. Okay, so I think this is the last intervention. How about the appropriate PPE in the wards, ICU, and emergency room in terms of the prevention of COVID-19 infection? So the reviewers found one cohort study, one case control, one cross-sectional, and one case report in to answer this question. So the results show that two systematic reviews, meta-analysis, reported on the association of COVID-19 infection with PPE. So the data on health workers in these studies were also considered. So 4 studies were included in this review. So reviewing all of these studies, the recommendation of the guideline is that among healthcare workers, we recommend the following PPE. So the approved recommended PPE for healthcare workers is a disposable hat, a medical protective mask, and N95 or higher standard, particularly those directly taking care of COVID-19 patients, goggles or face shield with anti-fog, a medical protective clothing, disposable gloves, and a disposable shoe covers or dedicated closed footwear as an effective intervention in the prevention of COVID-19 among healthcare workers in areas with possible direct patient care of COVID-19 positive patients and possible performance of aerosol generating procedures. So we have moderate quality of evidence here with strong recommendation. So I think that's the last intervention, and I want to end my presentation with this Swiss cheese respiratory virus pandemic defense again. So still emphasizing the importance of non-pharmacological interventions in the prevention and control of the spread of COVID-19, of SARS coronavirus 2. So I just want to acknowledge here all the evidence review experts, because the panel and the steering committee base our recommendations from their review. So we'd like to acknowledge them and also the project staff. So thank you very much, and here are some of our references. Thank you.
Thank you so much for that insightful discussion, Dr. Rojas and Dr. Alenjandria. Alenjandria, may I call once again my colleague, our chapter chair, Finance Committee, Dr. Jason John Cabigon, for the open forum.
Thank you, Dr. Ku. Magandang gabi po sa ating lahat. Ako po ulit si Dr. Cabigon at ako po ang magiging moderator niyo po ngayong gabi. So first of all, let me read the messages of congratulations sa ating chat. Thank you for the presentation, very insightful. Thank you for the lecture, Doctora. Stay safe. So thank you once again sa ating mga distinguished panelists, Dr. Alenjandria and Dr. Roxas. So to start off po siguro, there is one burning question that I can direct for both of our speakers. Maybe sawang-sawa na kayo dito, Doc, sa question na to, no? But some of our participants are eager to know the answer, and this is about ivermectin. So even if it's not part of the presentation today, any recommendation po ba from the cluster regarding this drug? Maybe we can start with Dr. Alenjandria.
Okay. We did review ivermectin, no, in our living CPG. So we look at the evidence for treatment, and we were able to in RCTs. And our recommendation is there is insufficient evidence at this time to recommend the use of ivermectin for mild to moderate COVID-19. No? Because in the RCTs, I think that's about 7 or 8 RCTs on mild to moderate COVID-19. There is some trend, no? It is showing some benefit in terms of reducing mortality, but the quality of the clinical trials is very low. No? Okay, so we have we are very uncertain, no, on the benefit that we are seeing. So we need more data from well-conducted clinical trials. Okay, so that is why our recommendation is insufficient evidence for now, for mild to moderate. Now for severe COVID-19, we suggest against the use of ivermectin for severe and critical COVID-19, because we only found, I think, 1 or 2 trials, and it did not show any benefit in terms of reducing mortality. So that's our recommendation, no, in the living CPG, based on the consensus panel also. No, this was voted upon, okay, by the consensus panel. For prophylaxis, we are also not recommending the use of ivermectin as prophylaxis. We only found we found 3 randomized controlled trials. Again, very low quality. So the panel opted to vote against, no, the use of ivermectin as prophylaxis at this time, because they gave a greater value to the potential impact, no, if we use ivermectin or if we recommend it for prophylaxis, and knowing that there is still very uncertain benefit, and we also are not sure of the safety, no, in using this as prophylaxis, how long we are going to take it. The false sense of security is given a greater value, no, that you think that you are protected while taking the ivermectin, and then also the potential collateral consequence, no, people might opt to just take the drug rather than get vaccinated, no, when we all know that the trials, no, the results of the vaccine trials are actually highly efficacious, no, in preventing severe disease, in preventing symptomatic infection. Okay, so would like to recommend vaccines, as for prevention of COVID-19 based on well-conducted large clinical trials showing evidence of protection. Okay.
Dr. Rojas, any thoughts?
I have no other additional comments. So Ma'am Isa said.
Thank you. Very, very, very clear yung ating direction towards ivermectin. So, Dr. Rojas, the next few questions are regarding sa mask. Maybe if you can enlighten us. And we are very fortunate. As of now, we are sitting at 363 participants. Ang dami po, no? And some of them are actually non-medical. So maybe we can ask for enlightenment regarding, usong-uso na naman to, Dok, sawang-sawa na kayo magsagot nito regarding copper mask. Kasi daw ngayon meron ng filter yung copper mask. Meron daw po bang benefit yon? And just a follow-up question para lang po tuloy-tuloy na rin po yung discussion. For the benefit of those na non-medical po, ano po bang maganda po talaga, surgical versus KN95 versus N95 or even double masking?
Okay. So thank you po, Dr. Cabigon, for that question. So thank you for all those who asked that question. Sige po. So siguro, Ma'am Isa, no, kailangan talagang mailagay namin sa non-pharmacological intervention question yung copper mask. Although we've tackled the other mask, pero wala pa kasi yung review. So yung official review for the use of copper mask. However, because of that, wala pa kaming recommendation, pero ang meron lang is that ang nirecommend, ang malinaw po dun sa visa studies is that ang nirecommend for the general public, okay, in the community is a cloth mask will be sufficient. So yung usual cloth mask po ay sasapat na para sa for the purpose of the mask. But in other situations, like for healthcare workers na nagtatrabaho po sa ospital and might be directly attending to a COVID-19 patient, a cloth mask will not be sufficient. Ang kailangan po for those healthcare workers not directly taking care of COVID-19, minimum po ay surgical or medical mask. And kapag those healthcare workers directly taking care of COVID-19, higher than surgical mask, yung N95 po na tinatawag natin. So nabanggit mo yung KN95. So KN95 po, actually sa ibang lecture ko, sinasama ko po yun, difference ng KN95 kay N95. K lang daw. Hindi, joke lang po. So si KN95, meron yung tinatawag na total inward leakage po. So it has a total inward leakage po ng up to 8%. So meaning, pwede pang may makapasok po na air with KN95 as compared to N95 which has zero TIL or total inward leakage. Kasi ang N95 is really for airborne, di ba? For mga airborne organisms. So for airborne precaution, the recommendation is to really use N95. So si KN95, meron siyang 8% na possibility na pwedeng pumasok si air. And as we all know, si SARS-CoV-2 up to this time, still the main mode of transmission ay respiratory droplet na maaari lang ma-aerosolize, and there are some instances na pwedeng ang katapat niya na transmission is parang airborne kung may mga instances lang like kapag gumawa ang doktor ng mga aerosol generating procedures. So with this, pwedeng ma-recommend pa rin ang KN95, particularly for healthcare workers not directly taking care of COVID-19 or not performing aerosol generating procedures. So yun po.
Okay, thank you, Doc, for that very clear na recommendation. Moving forward po, the next question is about vitamin C. So maybe, Doc Alenjandria, maybe if I can direct this to you. In the living recommendation daw po, there is insufficient evidence with the use of IV vitamin C. Is there any recommendation towards oral vitamin C?
Okay. For COVID-19, we did not find any evidence on the use of oral vitamin C for COVID-19, yung direct evidence. Kasi what we have only is the systematic review which I showed noon, its effect on viral upper respiratory tract infection, so non-specific siya. So kaya wala kaming recommendation on vitamin C as directly having an effect on COVID-19. We do not know. Sa IV vitamin C, there is no benefit. So most likely, wala rin sa oral. Ang effect lang niya is for the usual upper respiratory tract infection. It can decrease the duration of common cold. And then when you are under stress, it can boost your immune system.
I see. So as a follow-up question lang, Doc, your table is very, very clear, yung last slide niyo po. And it seems that most of the vitamins, minerals, and supplements, like the BCO, like the melatonin, parang may insufficient evidence. But since leaving recommendations, many are still under study. Meron po bang promising dito po sa mga may insufficient evidence? Parang sneak peek?
I wish that there are. I really can't predict which of those with insufficient evidence will fulfill its promise. Let's see, kasi there are a lot of ongoing trials on those with insufficient evidence. So, natin which of those. On the other hand, even if it doesn't show, we all know what are their diba, yung indications naman ng zinc, vitamin C, vitamin D. May use pa din naman siya. It's just that it's not a direct treatment for COVID-19 sa ngayon. So we don't know kung may add-on benefit pa siya.
Thank you, Doc. Totally understandable. The next few questions po will be about the additional PPE. So maybe I can direct this to Dr. Rojas. So siguro isang rundown lang po with the PPEs. So there is a comment regarding if there is little evidence sa face shield, why are we still recommending face shield? Another, siguro idagdag ko na rin pahabol yung KF94 na mask. So, meron po ba tayong evidence for that? And also yung mga air filters. So, I think you touched a bit on that already. So, just a quick summary lang po ulit of those recommendations. Thank you, Doc.
Okay po. So, for face shield, so based on the reviews, so kahit na maliit na benefit, but when we presented this to the panel and in a way, yung benefit, additional benefit, risk, hindi naman ganun ka-risky. Kaya ang naging recommendation po is to include face shield as part of the recommended PPE. Kasi it has an effect din po dun sa mode of transmission din kasi. So as we all know, yun nga, sabi namin, human-to-human transmission pa rin, respiratory droplet. So that's an additional barrier, aside from the face mask. That's why we included face shield as part of the recommended PPE po. So with regard to the KF94, actually hindi pa po ako nakakita ng KF94, pero na-search ko na siya. So sabi lang is less than 1% filtering capacity. So kanina na-explain ko na yung difference ni KN95 sa N95. So actually, yes po, pwede namang gamitin ang KF94, but again for kasi yung recommend namin for aerosol generating procedure talaga, the recommendation is N95, that's the minimum or higher pa nga na respirator. Tapos yung sa filters po, purifier. Okay po, so since kita namin sa review that walang gaanong direct benefit and it has a harm pa with the production of ozone, that's why maraming magagalit na manufacturers, pero the CPG recommend against the use of purifier. So because of this po, kasi nga walang direct benefit, tapos may possibility pa of harm. So yun po yung basis why we do not recommend it.
Thank you, Doc. What about, Doc, some additional protective measures like barriers, mga acrylic barriers? And also there is one, before we totally leave the topic of mask, what about double masking daw po using cloth mask? Is there a benefit for that?
O nga po kasi natanong mo na yun actually sir kanina no, pero na-skip ko ata. Sige po, so yung acrylic barriers muna, ang dami nating idadagdag sa NPI. So naka-line up din po yan si acrylic barrier. So before, nire-recommend as part of the engineering control po si acrylic barrier. So it's included in the engineering control, so barrier to prevent the transmission again, based on the transmission of the virus, which is via human to human and then respiratory droplets. So before ni-recommend, but I think kailangan po namin talagang hanapan ng evidence and study that will recommend or will not recommend this acrylic barrier as an effective preventive measure against COVID-19. Sige po, so isama po namin sa next update. Dalawa na, copper mask at acrylic barrier. Okay po, so double mask, although si CDC na balitaan po namin nga yan, double mask, but here hindi pa po namin sinama sa living CPG. Although si double mask ay nire-recommend or ginagamit po as a form of protection po sa, for example, sa mga healthcare workers on N95 that they want to parang i-preserve yung N95 nila that they can use it, okay, or reuse it. So pwede pong mag-double mask para magamit pa ulit si N95 and hindi directly na ma-expose para kumbaga. However, double mask as a measure really to somehow better way of preventing. So hindi pa po namin nasama sa COVID-19 living CPG as of now, so I cannot comment. But double mask as a way to preserve the integrity of N95, so pwede po namin yung gamitin.
Thank you.
Siguro add ko lang just yung double mask. Kasi I think what's important is the mask is snugly fit. Yung maganda yung fit niya, walang masyadong pumapasok. So yung iba, I think that's one of the purpose kaya din na double para yung fit mas siya. Walang air na pumapasok. Oo, nag-i-skip. Yun lang.
Follow-up question lang po, Doc Alenjandria, dun sa double masking. Meron po bang certain recommendation if KN95 yung nasa loob or surgical mask ang nasa labas? Kasi I have seen some medical practitioners doing double masking using different types of mask.
Diba?
Sige po. Siguro, actually, parang guilty ako dyan. Hindi, I do that kasi nga po, to preserve yung N95 ko. So, I have my N95 sa ilalim and then I use surgical mask on top of it para pwede ko pa siyang magamit. So, yun yung sinabi ko kanina po. Pero wala namang strict recommendation na dapat sa ilalim talaga N95 or surgical mask on top of it.
Yung iba naman, yung sa public, surgical mask tapos cloth mask over it. Meron. So, basta important naman yung pagsuot at saka well fit.
Ayun po. So yun sir, I want to ulitin yung sinabi ni ma'am na yun nga, kahit na ilang mask po yan, kung hindi properly worn, so wala ring effect si mask po.
Okay, thank you. Nanganganak yung questions natin regarding sa mask. So you mentioned po a while ago about UV, the use of UV light to disinfect kasi you mentioned that putting chemicals are not recommended to disinfect mask. What about sun drying, Doc?
Sige po. So kanina na-enumerate namin yung mga recommended decontamination processes. So wala pong mention ng yung sun dry or air dry. Kasi actually ang nire-recommend po lang namin is after use para ma-preserve nga yun nga, pwede namang ma-reuse ang N95 ay ilagay lang po sa brown bag. So brown bag lang recommend. Hindi plastic kasi sometimes si plastic po ay magkukos ng moist and can, facilitate growth of bacteria. So kung i-reuse nyo po siya, so ang recommendation 2 to 3 day use ng N95, ilagay nyo lang po sa brown bag after every use. Tapos kung gagamitin mo, kunin mo lang doon. So yun po ang recommendation.
Thank you, Doc. Very specific recommendation. The next question, medyo unique po itong question na to because it's about composition of your committee. So maybe Dr. Alenjandria can answer. It was mentioned a while ago that foot baths are not recommended anymore. However, for most of the occupational physicians, nasa checklist po ng DOLE yung foot bath. Meron po bang DOLE representative po sa committee or meron din po bang take yung department in such issue?
Okay. Yung history ng foot bath, kasi nag-start early part of the pandemic, I think that started yung parang sa Italy ba yun, yung shoes daw ay nagke-carry ng virus, no? But the way we implemented it here kasi is may disinfectant pa. So there is really no data, no, on the effectiveness of the foot bath. What we have is a lot of experiences na harmful, no, mga nadudulas, and then it's also causing madumi, diba? It adds to the and it's not being maintained naman properly. How do you really clean it, no? So it doesn't really add to protection, no, against preventing COVID-19. So we will be, kasi these guidelines will actually, it's DOH is part in the committee, so we are endorsing this to the DOH so that they can change, no, the guidelines with regards to the foot bath, the use of misting tents, ano pa ba yung mga ionizing air filters para magkaroon ng official circular, no. So I've also presented this already to the Department of Health then, and because they're part of it as well. So eventually wala pa lang yung official circular on the changes, no, on this.
Thank you, Doc. Thank you, Doc, for reassuring us. Takot lang po kasi siguro kami
Yeah,
na mas
kasi yung workplace handbook, which was done last year, no, nandun pa yata siya nasa checklist pa rin, ano, hindi pa natanggal.
Thank you po. So at this point po, I think we addressed already most of the questions. So if we can ask for some take-home message from our distinguished panelists, maybe we can start with Dr. Roxas.
Sige po. So particularly for the non-pharmacological intervention po, so ang sinasabi namin parate, ang tamang pag-prevent and control will be effective kung alam natin yung main mode of transmission po ng virus. So that we will not have all of these unnecessary control measures, we have to know what is the actual mode of transmission ni SARS coronavirus 2. So, and we want to emphasize na up to this time, still the main mode of transmission is human to human, particularly via respiratory droplet, kasi po yun yung characteristic ni virus. But in some instances, again, like aerosol generating procedures or in areas where there is no appropriate ventilation, the possibility of airborne transmission for SARS coronavirus 2 can happen because it can be aerosolized. And another mode of transmission, although not as that big mode or main mode of transmission as that of human to human, is via contaminated surfaces or by fomites. Pero may recent study nga with CDC that the transmission via fomites for SARS coronavirus 2 is very minimal. So actually very minimal. So yun po. So kung alam natin kung paano natitransmit ang virus, then malalaman natin bakit itong mga interventions na to ay hindi effective or is not recommended at bakit itong mga interventions na to ang nire-recommend. So yun lang po. Thank you.
Thank you very much, Doc. Dr. Alenjandria.
So I'll start off with again the preventive measures, no, kasi in infectious diseases ang maganda sa infectious diseases, if you implement the preventive measures, then you are able to control, no. So sa COVID-19 sa ngayon, unfortunately wala pa talagang what we call yung drug, no, for mild to moderate, no. So for severe critical, we have steroids, no, and tocilizumab, but for mild to moderate wala pa. So for the prevention, apat dapat. So yung air circulation, physical distancing, always wear mask and reduce your time of interaction, plus vaccines, okay, no. So if your turn comes, get vaccinated, no. So the vaccines are very effective in preventing severe infection and hospitalization. It also prevents symptomatic infection. Okay, so let's encourage, no, each and everyone to get vaccinated, so that eventually we will have enough that are immune, that has some form of immunity, and will be able to control the pandemic. On the other hand, if you do experience symptoms, consult right away, isolate, no, isolate yourself, do not go to work, isolate, and then get tested, no, and then inform your household members who are potentially got in contact with you, so that they will also be quarantined. So prompt isolation, prompt quarantine, prompt testing. So kasi we all know naman na majority of COVID-19 is still the mild form. Okay, so less than 10% go into the severe form, and alam natin yung mga who are at risk, no, yung elderly and with comorbids. So sila yung at risk. And so with regards to treatment, so yung mild, ang main form of treatment pa rin is supportive care, no. So quarantine, supportive care, so antipyretics, fluids. Wala pa talagang definitive drug that has been shown to have definite benefit, no, in terms of preventing progression to severe disease. Okay, so yung mga adjunctive interventions natin, majority insufficient evidence, it can boost immune system, but it does not directly treat COVID-19. Thank you.
So with that, we will be ending our open forum. Thank you very much again to our distinguished panelists and to all participants. Dr. Ku, back to you.
Thank you, Dr. Cabigon. Thank you to our panelists, Dr. Rojas and Dr. Alenjandria, for that wonderful, insightful discussion. Thank you, QCC Virtual Kapihang team. Excellent job to everyone. Pinapangunahan po ng ating PCOM QC Secretary, Dr. Jose Angelo Taylor. Maraming salamat po sa mga nag-participate ngayong gabi. Sana marami tayong natutunan. To formally end tonight's educational activity, ladies and gentlemen, our Chapter Vice President, Dr. Jeremias Martin Florente.
Thank you, Dr. Ku. Another night of great learning has been finished. The Quezon City chapter hopes that we have learned something tonight, and this learning must be shared as well to our colleagues at work for the safety and health of everyone in our workplace. In behalf of the chapter, we would like to thank Doctors Marissa, Alenjandria, and Evalyn Roxas of the University of the Philippines, Manila, National Institutes of Health, for their expertise shared in our tonight's Kapihang. Certain matters were brought into light regarding non-pharmacologic and adjunct interventions in managing the coronavirus disease 2019. Likewise, we would like to extend our deepest gratitude to our partners in the advocacy of occupational safety and health, the safety officers, company nurses, human resource personnel, managers, security leads, government-accredited occupational safety and health practitioners and consultants, among others. Thank you also to the national officers and board of directors, headed by Dr. Phil Pangilinan, and to the members of the Philippine College of Occupational Medicine from the other chapters for gracing regularly our Kapihang. To our past national and chapter presidents, and to the members of the specialty board, thank you. Special mention to the rest of the Quezon City chapter officers and board of directors, including its general membership who are here tonight. Not to mention our very own webinar technical team. Thank you very much. Your hard work, despite all the challenges, is everyone's success. At this juncture, allow me to invite everyone to the premiere night of our special edition of Kapihang OH, commemorating the 2021 World Day for Safety and Health at Work. It will be replayed in our official YouTube channel at around 10 o'clock this evening. So I am inviting everyone to like, share, subscribe, and hit the notification bell of our YouTube channel so you will get updated of our videos. You may also like and or subscribe to our other social media accounts posted in our screens tonight. Should you have questions and suggestions for our future Kapihang topics, please do not hesitate to email us at pcomquezoncitychapter@gmail.com. Again, thank you everyone. Always remember that in Quezon City chapter, we value your safety and health. Hashtag PCOM QCC cares. Good evening and stay safe and healthy.
Thank you, Dr. Florante. Muli, maraming salamat sa inyong pagdalo. Sa susunod na 29th Kapihang OH, ako po si Dr. Margo Venus de Salyacu na parating nagpapaalala na sa Quezon City Chapter, ang inyong kaligtasan at kalusugan ay mahalaga. Hashtag PCOM QCC cares. Good night, everyone, and stay safe and healthy.